Bismillah ar-Rahman ar-Rahim. Hello, everybody. Good evening, everybody here in Egypt, and good afternoon in Brazil. And we are continuing again our online meetings and the online working in the field of ophthalmic education regarding the anterior segment surgeries. And I'm honored today to have my dear friend, my close brother, Dr. Bruno Fontes from Brazil. Is a very expert cataract surgeon and consultant of cataract and refractive surgery in the Opti group eye centers in Brazil, and is also the president of the Brazilian Society for the Cataract and Refractive Surgery or Refractive Surgeons, which is called the BRASCRS, one of the very great and big societies in the field of anterior segment surgery. And it's also one of the innovating and indicating societies in the field of the anterior segment surgeries, including the refractive and cataract surgeries in the Brazil and the Latin America and everywhere. Thank you, Dr. Bruno. It's my honor and pleasure to have you today in the Ziada Eye Academy Zoom meeting.
Thank you so much for the invitation. Thank you for everybody for all of your kindness. And it's a great pleasure to be here and show some interesting cases.
It's our pleasure, really. And we are using all meetings you share with us to show the unusual and the fantastic cases with your talent, with your expertise in the field of cataract surgery and how to deal and manage with the unusual and very difficult situations. Please, sir, we are waiting for your surprise today.
Okay, I think you have to allow me to share my screen.
Yeah, right now I have allowed you, sir. Start sharing.
Here we are. Can you see my screen right now?
Yeah, perfect. Yes.
Okay. This is an unusual case of iridoschesis, where the iris it gets split in this tissue. It's most commonly in very short eyes after uveitis, especially toxoplasmosis, which like somewhat common here in Brazil. You have Scheimpflug images right here. And you can see that I showed before, it was the microscope image of the beginning of the surgery. But here is the patient in pre-op screening. You can see here the iris, the tissue, it spreads, it gets separated in different tissues. So it gets some iris fibers keeps touching the corneal endothelium and keeps hurting it. So we have here on corneal edema, a very shallow anterior chamber, which like one of these features of this syndrome, and a very hard cataract. Here you can see the pachymetric map. You see it very shortly. When you can see where there is a huge corneal edema, especially in the area where the iris is touching the corneal endothelium. It's more common in short eyes, in short anterior chambers. It's more common in the temporal inferior region and after uveitic cataract. So here's the beginning of the surgery. Remember, it's a very short anterior chamber, so have to be very careful when you do paracentesis. I like doing a triplanar and corneal incision. I think it's more stable. Let me just touch it here. Oh my God. Here, so the beginning of of surgery, very carefully doing my incision because it's a very shallow anterior chamber, putting some dispersive viscoelastic, and with the viscoelastic cannula, just releasing this posterior synechia. Remember that this eye has some uveitic toxoplasmosis before, and toxoplasmosis can cause a pan-uveitis in the posterior pole in the anterior segment as well. So I'm releasing those synechiae with the viscoelastic and trying to remove it 360, because I know it's a very difficult eye to work on. I'll have a limited space, and I have to use some iris hooks here to help me. When I have such a shallow eyes, I'm always figuring out why, if I am using the Malugin ring or some iris hooks, some individual iris hooks. When it's very, very, very shallow, I think it's better to use the iris hooks individually. This eye, I could put some viscoelastic. I got some more deeper chamber, and I thought it would be better to put the Malugin ring, because I can put and isolate the iris fibers. It's very hard to manipulate this eye because it's very shallow, and it will be challenging to perform a capsulorhexis. And here I'm removing the viscoelastic in the anterior capsule, so I can stain with trypan blue. And trypan blue, when you have some viscoelastic in the anterior chamber, is difficult. If you have to wash it out, otherwise it won't. You will not stain the capsule. The corneal edema was making very hard, very difficult, so I decided to remove the corneal epithelium to improve my visualization. And it got a lot better without the edematous epithelium. Here we can perform a anterior curvilinear capsulorhexis with the Malugin ring in place. Remember, it's a very hard nucleus as well. We cannot perform such a small capsulorhexis. With small rhexis, you have some difficult times dealing with the nucleus. It can cause zonular and changes, trauma. My technique is phaco shop. I use it in every case, almost every case. You put a lot of high vacuum and use the Nagahara chopper to break the nucleus. Here is a very, very hard nucleus. Once it's broken, it's cracking, you can use it, you repeat the maneuver and speed it in smaller pieces. So you have to have a very loose nucleus, a good good hydro dissection. And here I'm just splitting and chopping and making it in very small pieces for phacoemulsification. Phacoemulsification, just here we have to aspirate all the cortex, and it's difficult because you can see here superiorly that some fibers of the iris here, they are not close into the Malugin ring here. Some fibers are close. So I have to remove everything, implanting the IOL, which is a foldable IOL, that it's an Microsoft IQOL, entering a 2.2 corneal incision. As soon as it's positioned, let's lose the Malugin ring, remove it from the eye, and then I have this problem: what to do with those iris fibers? I cannot leave them like this way, because otherwise it will keep traumatizing the corneal endothelium. So the cataract, it's done, but I have also already to deal with those loose iris fibers. I cannot just leave them here, otherwise it will have still traumatizing the corneal endothelium. So there is a surgeon over here in the south part of Brazil, Emir Ganem, who has a lot of patients like this, and he described this technique. Here's the anterior retractor to cut these loose fibers. For this way, it won't traumatize the corneal endothelium anymore. I have to remove all these iris fibers. At that time, I mean, at the surgery, I just cut this fibers, this atrophic iris, and I planned to do to reconstruct the iris in a second surgery, or even perform a corneal tattoo You see how it was in the post-operative week. Let's close the surgery. Some weeks after the surgery, the patient is looks this way. I mean, there's no corneal edema anymore. You remember in the first time I saw there's a lot of edema here because it was secondary of the iris fibers traumatizing the corneal endothelium. I removed those fibers here. I planned for this patient a corneal tattoo here to not because of cosmesis and a better vision, but this patient, she had a macular scar. So the central vision wasn't good because of toxoplasmosis. I mean, toxoplasmosis was one of the cases of this hydrodischisis. And then she was satisfied and she did not want any surgery anymore. So that's the case of unusual iridoschisis.
Thank you, Dr. Bruno, for this very difficult case, actually. But God was with you. You was lucky with this very small and very tight anterior chamber. You are doing a lot of the significant and manipulations in this very tight field. And they are trying to keep the endothelial cells, which are healthy in the other parts of the edema. It was amazing. Thank you very much. But let me to ask you about two questions.
Okay, I can share with you some more videos, but let's discuss this video.
Okay, a very short discussion about it to get another amazing videos. The first, I read these cases is with the special types of uveitis or could happen with the all types of uveitis.
I think it can happen with all types of uveitis. I mean, it was described here in many patients with toxoplasmosis. Toxoplasmosis is very common here in Brazil.
Yeah.
And it's more common in the south part. So that surgeon that I told you that he described the technique using the anterior vitractor to cut the iris fiber is from the south part of Brazil, Emir, because he has many patients with it. If we leave the iris like that, it continue to traumatize corneal endothelium and have the persistent corneal edema.
Okay. The second question about why didn't think in iridoplasty to take suture to add these parts together?
Good. I planned to perform it in the second surgery because I didn't know how if the corneal endothelium the reminiscent will survive and get a clear cornea after that, because she had a very bad corneal edema. So I thought to plan it, have it the eye gets quiet, and then plan for a second procedure. I would think about or a iris suture or a corneal tattooing.
Yeah.
Corneal tattooing, it's wonderful. It do not traumatize the reminiscent corneal endothelium. It had got some good corneal cosmetic results.
Yeah.
And that was my proposition. But the patient was very satisfied. She lost his vision of these eyes a lot of years ago, and she was satisfied. Not having the eye burning and red as it was because of corneal edema.
Totally different. Yeah, the picture postoperatively is totally different. It's very resting and very relaxed eye, very quiet eye, and it was very angry before the surgery. But do you expect that the patient may benefit from this lost part of the iris because she has a macular scar? So this part of the 18 iris may help her for the peripheral vision?
I don't know, because the capsule got a lot of fibrotic tissue at that time. I mean, so the periphery it's opaque. I think she's watching or seeing with the central part of vision.
Okay, I think the fourth row stage of agrawal will be suitable for this case with less manipulation. Yeah. If you haven't done it yet, I think the fourth row stage will be easier without
Yeah.
injury. I had a case yesterday after the ruptured globe with elongated and lost part of the inferior iris. It was very nice and helpful technique.
Yeah, I performed the fourth row in a patient with a corneal transplant, penetrating transplant, with a lot of astigmatism in a pinhole, like the Dr. Agarwal described it. It helped. I mean, it's working.
Yeah. Okay, it's great. I'm hoping to see my patient on Sunday to get some improvement of the vision because he has a scar in the lower cornea with a very high astigmatism. So I pulled the iris up to the center, hoping to be away somewhat from the irregular astigmatism and get some vision. Anyway, I will tell you about this case and to share it together. Okay, my friends, you can go ahead in your videos.
Okay.
And, give us
let me share. I mean, like some videos of zonular instability and lens subluxation.
Yeah.
This. Oh my God. Let me just. I don't know what I did wrong here.
Yeah, take it easier. Close it from here.
Oh, here. Let me just.
Yes. You can enlarge the screen.
Full screen.
Yes.
So some cases of zonal instability. This patient has a very advanced pseudo-exfoliation. You can see the crystalline lens is 100% loose. I mean, it's floating in the anterior vitreous. I know that Dr. Ahmed would use like a lot of hooks to perform this case, but at this case, I planned like intracapsular crystalline extraction, but I did here. Extract it was all loose, and then do perform some stitches. It's very important to keep the positive and gradient. Is very important to not have hypotension for a long time because of the risk of hemorrhage. So after anterior vitrectomy, this is planned for iris suture. So that's what I did at that case. This case is a case of subluxation is in a kid, in a child. And here it's the most difficult thing is to perform the capsulorhexis because the anterior capsule of this kids, it's very fragile, and it always comes to the periphery. So you should perform it in a very controlled and in slow motion way. As soon as you get the complete capsulorhexis, it's not difficult to aspirate the nucleus. So here, completing the capsulorhexis and then aspirating the nucleus. It's soft nucleus. I think it was a case of Marfan syndrome. In this case, you have intact anterior hyaloid, which is and the feature is very robust, and you always have some zonular fibers that you can help you. Here's another case. I think it's the same patient in another eye. No, this is a traumatic case. Here you can only aspirate the nucleus. Is very difficult. Everything is coming, and so sometimes you have to use these rings to stabilize these capsular rings. They're very useful. You should always have those micro forceps and all these hooks, iris hooks and capsular tension rings. This tension ring is very important to use in cases like that. Well, as soon as you put the ring, if you don't have like a very big subluxation, it will help you and get it very stable for the end of the surgery. Here's another congenital case. I think this patient has a Weill-Marchesani syndrome. Well, it's challenging as well. Some have the lens coloboma. The most challenging thing here is to perform the capsulorhexis. As soon as you have the capsulorhexis, the rest will be like very more easily performed. What I did in this case, I put the lens in the circles and put it inside the bag and use it all the complex and suture in the iris. So I just put the haptics in the bag, and then I put everything inside and suture in the iris. I like iris fixation. I don't know that many people don't like it a lot, but I like iris fixation. I had some protocols here putting artisan lens in Marfan syndrome, and it works very, very good. So here, finishing the IOL positioning, and that's it. It's stable, and that's the video. So I just showed some cases of zonal instability and IOL fixation.
Perfect, Dr. Bruno. It's a very good experience and very guiding and stimming at the same time. But I want to ask about the iris fixation. The iris fixation is a very good technique and it's not easy, by the way. But the main problem which make some surgeons objecting about it, the pupil constriction. They are thinking in the future, if we are gonna dilating the pupil or to do something in the posterior segment, it will be limiting. Tell me about your solutions if you have.
Yeah, I have a lot of patients that we can dilate and perform a fundus examination without problem. I mean, I don't think that's a big issue. The main limitation is that you have to have a healthy iris tissue to suture the IOL on. Whenever you have like a lot of iris atrophy or some malformation, then it's possible to do so. There are so many IOL fixations and techniques. I think the surgeon should like always study and know more than one. But then you have to, I think you have to choose for like 2 or 3 techniques, because it's not a very common surgery. So to get experience in one technique, I mean, you have to focus in 1 or 2, because otherwise you are not a different surgery and it never be a very good one in all surgery, in all techniques.
Okay, you mean that it is preferred way of correction of aphakia? If you don't have any support, capsular support or aphakic patient, you will put the iris fixated lens?
Yeah, nowadays I focus on 2 techniques. Yeah. When the patient has a healthy iris tissue, I prefer for iris fixation. When iris fixation is not possible, I like the acryls and Gore-Tex fixation sclera 4-point. 4-point using the acryl, Bausch & Lomb acryls IOL. I think it's very good. I perform the Yamani into patients, but I mean, I like very much the stability of the Gore-Tex with 4-point fixation acryls IOL. I mean, that's the 2 preferred techniques that I use mostly in my patients.
Do you have a video for this technique?
Sorry?
You have a video for this Gore-Tex IOL?
I have, but it's not in this computer. I'm sorry. I'm sorry. It's not in
we may have it in the second meeting.
Okay, it will be a pleasure.
To show a new technique for our colleagues. But what about the glued IOL, the scare fixation glued IOL? I know that the AMR is showing it many times in everywhere, even in Brazil. So what's your opinion and what's your experience?
It's very popular. I mean, it seems that it's amazing. I haven't done it yet. You have to have a good partner to do surgery with you, because you need the help of another surgeon. And sometimes it's difficult for me to operate with the help of another physician. Many times I'm doing surgery by myself alone. So I prefer to do techniques that I can handle all by myself.
Yeah, okay. I agree with you because I have done it more than 10 cases, but actually it was so difficult and stressing because it needs the second surgeon or the assistant, a good assistant on your side too. I depended on the nurse assistant, but it was not as I needed all the time. So I got some troubles and problems with the stretch of the flap, with the stretch of the haptic, and I got cut haptics in one case, and the other one slipped from the tunnel. But it's actually it's a good technique, but it needs somewhat a learning curve. Also needs some preparation. You have to get some forceps, many types of the micro forceps. Also, you need support by the AC maintainer or the pars plana trocar with infusion if you got posterior segment surgery at the same time. But I agree with you that the iris fixation, the iris fixated lens is very good. If you could put the iris suture or passing the iris stitch successfully without injury to the cornea or the other parts around this point. I want to ask you also about the IL. I have seen the IL implanted in cases of subluxated lens, the AcrySoft one piece. What about the three-piece IL? Do you think that the haptic of the three-piece will support and help the subluxated part of the capsular bag and may help the capsular tension ring or not?
Yeah, when you put the three-piece IOL in the sulcus, sometimes it gets some fibrosis in the haptic and helps to stabilize the lens in the long run. We have some pictures shown in many meetings around the world. Because one problem we have is that Prolene sutures, it can break in a long run. I mean, if the patient is very young, sometimes you have to reposition the lens in the long run. I mean, it's not the end of the world, but you have some cardiologic issues, problems that you have to change the valves and do chest surgery repeatedly. So, I mean, you can reposition IOL if it get loose. The one-piece AcrySoft IOL is not suitable to implant in the sulcus because it causes the pigment dispersion, the uveitis, and emphysema syndrome. The three-piece IOL, you can use in many different situations, and you have always to have this three-piece IOL. You have the sensor piece, three-piece from Johnson & Johnson. You have the three-piece IOL from Zeiss, which is more suitable for the Yamane technique because I think it's more flexible and longer. I mean, the three-piece, they are marvelous. You have always to have them because you can use it and in different situations, in different techniques, and the patient to not get a fake kick.
Yeah, okay. You know, Bruno, that the problem with the Yamane is the tilting of the lens. It's not supported and not stable all the time because of the free haptics. On the other side, the Agrawal's externalized haptics is more supported because the haptics are buried in square tunnels. So it's tightly stretched and supported if you placed it in the right position from the start. But finally, maybe the last question about this video. It's better to do lensectomy with iris fixated IL or scale fixation IL, or to correct the subluxated bag and put the IL inside the bag? Which is better for both the surgeon and the patient? Which is better in your opinion?
When we used to watch those wonderful, marvelous videos from Dr. Ike Ahmed from Canada, and he always struggling to get the capsular bag. If it's possible to keep the capsular bag, it's better. But one thing that I mean, the main message here, there's so many IOL fixation techniques, but I think everybody should be very careful about the anterior vitrectomy. That's the most, I mean, the key message. Don't leave vitreous in the anterior chamber. I mean, you don't want vitreous there. Vitreous in the anterior chamber will cause secondary glaucoma, secondary uveitis, secondary macular edema. So whenever you use your IOL fixation technique, it's fine. There are several different techniques, but in all techniques, you have to perform a good anterior vitrectomy. Don't leave vitreous behind the chamber. So I think the key message here will be not the technique, but I think the basic one will do not leave vitreous in the anterior chamber.
Perfect. Thank you. But I want to clarify some point for me. You may agree with me or disagree about the capsular function. If you kept the capsular bag, you will still have some accommodation, some power of the accommodation, with especially in the young age. I have seen such observation in patient in two patients after lensectomy and scleral fixation IOL, and the other two patients who was younger than the age of 15. I kept the capsular bag and implanted the IOL inside the bag with the CTR. I noticed, and I may be right or not, I noticed that the patients with a kept capsular bag have some accommodation and could see some near vision, especially the medium and large brains, while the other patients with lensectomy couldn't, with the same refraction. What's your opinion?
Yeah, in order to have accommodation, you have to have the intact zones. So you have to have the combined action with the ciliary muscle.
Yeah.
So whenever it's possible to keep the capsular bag and implant the IOL, that's the preferred technique. No discussion.
Yeah.
But you implant the IOL in the bag when it's possible, when it's not subluxated. If you have subluxation, you have some the zonular damage, and it's not able to accommodate. But you're right, like if you're going to a lensectomy and the zonular is intact, don't think twice. You have to put the IOL in the bag and keep it there. It's more natural, it's physiological, and it's the better choice for the patient.
Yeah, this depends on the zonular status. If you have a good and intact zonules, you may benefit from that. Otherwise, like in the old age subluxation, you will not. Okay, thank you very much, Dr. Bruno Fontes, consultant of refractive and cataract surgery in Opti Group, Brazil, and the president of the BRASCRS. Thank you very much for your time. And I know that you are busy and you are just coming from your work.
Yeah, I just arrived at home and I put my good t-shirt to play soccer with my son, because he's waiting for me. And as soon as I finish, I have to go running to play with him.
Okay, thank
you so much for
and God bless all of you. And waiting for other meeting to complete our series of the challenging and unusual cases of cataract. Thank you.
Okay.
And
thank you. God bless you. Bye-bye.